On today's episode, why one PHT treatment doesn't work for everyone. Welcome to the podcast helping you overcome your proximal hamstring tendinopathy. This podcast is designed to help you understand this condition, learn the most effective evidence-based treatments, and of course, bust the widespread misconceptions. My name is Brodie Sharpe. I'm an online physiotherapist, recreational athlete, creator of the Run Smarter series, and a chronic proximal hamstring tendinopathy battler. Whether you are an athlete or not, this podcast will educate and empower you in taking the right steps to overcome this horrible condition. So let's give you the right knowledge along with practical takeaways in today's lesson. I am in my echoey room at the moment. Hopefully it's all right. I'm starting to put a few things up on the walls, but I've just moved house and this would be my treatment room / podcast studio. And at the moment it's just completely plain. So there's a lot of bouncing of sound waves and hopefully it's okay. Today, I thought I'd do something a little bit differently. A few months ago on the Run Smarter podcast, I interviewed Alex Murray, talking about evidence-based practice and why one treatment doesn't work for everyone, different diagnoses. And I thought I'd take snippets away from his interview and chime in every now and then just to see how it applies directly to PHT sufferers. And so there will be a little bit of back and forth. Hopefully I've edited it in a way that's a nice, smooth listening experience for you, but we'll delve straight into the intro and then Alex talking about himself, and then throughout the episode I'll be chiming in, and I'll most likely split this into two parts because Alex's interview went for over an hour, and if I'm chiming in with some bits and pieces of myself, it might be best if I just split it into two, and yeah, we'll get his take, get my take, and just a whole bunch of value along the way. So let's dive in. Alex Murray is a podiatrist. He works in clinics in Canberra with the general population, but also with high performance athletes. He'll delve into in a second about his S&C training and all that sort of stuff. Alex Murray is also a clinician who collaborates with Cause Health, who essentially just how to best understand the body when it's injured. In fact, Cause Health do have this book, and the title is Rethinking Causality, Complexity, and Evidence for the Unique Patient. And that's exactly what we delve into today. So we talk about, first of all, the assessment and diagnoses and why it is so complex, and how the person as the individual factors into this, because we know it's not a clear-cut, cookie-cutter process, and it's not just one diagnosis label that everyone gets because everyone experiences it totally differently. It is a complex topic. It might require you to listen a couple of times, but this is really important because I often see a lot of runners very confused about their diagnosis, confused about why they get different diagnoses or different explanations that might have caused their injury, and then they respond differently to different treatments, and it just sparks a lot of confusion, a lot of anxiety, maybe a lot of just muddying the waters a lot, and we attempt to highlight that in today's episode and bring a lot of explanation, and Alex does an excellent job of that.
So I went to university in Victoria at La Trobe University, so that's where I did my undergrad, and thought I'd just be it's great university, and you just sort of leave thinking, yeah, I'm just going to go into a clinic, going to work really hard, help a lot of people. But then, you start to learn a lot more, and you see there's a lot more opportunities open. So I went and after graduating, I moved to Canberra. I worked with a Olympic medical team podiatrist. So I worked in his clinic, gained a lot of experience. And then through that went, well, I don't think I know enough. And went and did a postgrad with the University of Otago. So I did a sports and exercise medicine. Then after that, I went, still probably don't know enough. So I then started doing a lot of reading and educating myself as much as I possibly could. And then just people started asking me questions. So I eventually ended up sort of starting my own education. Started with a blog, which is now turned into an education company called Podiatry Systems. Still wasn't feeling like I knew enough. So I went and did my level 1 Australian Strength and Conditioning Association accreditation. So I'm now also a strength and conditioning coach. And then I'm still not feeling like I know enough. So I went and started pestering the people at Cause Health. So that's a research group in Norway. I thought their ideas were very, very interesting, and ended up partnering with them. So now we do a whole bunch of education around their thoughts and ideas about how pain, injury, things occur in the body.
Okay, so when you were going through that, I guess, year by year and not feeling like you don't know enough, were you also seeing like maybe there's a higher level of education or a better way to communicate to certain people, or you're just finding like missing gaps into how you were trying to explain things to patients? Like, where did that curiosity generate from?
I think there's always a curiosity deep down to sort of really figure out how things work. If I'm going to provide a treatment, if I'm going to, provide a diagnosis, I'm going to do anything to someone, I want to know that I'm doing the right thing and that I'm not missing anything. And so there's so much to know, and you're just like, I just want to know as much as I possibly can to do the best job I can. And I guess what I sort of realized, and this is sort of where sort of Cause Health came in, is that it really sort of challenged this idea that we know everything. And it actually sort of, Cause Health's work really sort of challenges a lot of the assumptions that we take into our understanding of the human body and our role as clinicians, and what exactly that we do. So we always used to think that, there was a complete cause and effect. There was one thing that we'd find, and if we just knew what that is and we could diagnose that and we could get rid of it, everything would be okay. And it's a little bit more complicated than that. So yeah, that's sort of where I ended up at the end of the road, is sort of realizing you can't know everything, but you also don't need to. We've got to challenge the way that we look at the human body. And that's sort of where we find the best answers and the things to keep people, running, moving, jumping, injury free, is sort of when we sort of let go of this. And you see the things all the time. There's this one trick that will solve all your problems. It's like, it's a lot more complicated that. And if we understand a bit more nuance, we throw away some ideas that we know are no longer useful, we can do a lot better.
Okay. I'm trying to put myself in the mind of someone who hasn't been trained in health science, and they think that, okay, plantar fasciitis is plantar fasciitis. Like patellofemoral pain is patellofemoral pain. It's one diagnosis, it's one kind of presentation, and there should be, okay, I have this, what should I do for treatment? So if we're talking about Cause Health, causality, and around about the topic of, okay, I have this diagnosis, therefore let's just follow there should be like one cause for this one diagnosis, so let's follow this treatment path. How would you explain to a patient the causality, the complex nature of causality, and why there isn't just one cause to one injury?
Yeah, very, very good question. I think what one of the assumptions that we have, which you hit straight away, was that we're looking at, if you have one injury, one process, something happen, that there's a direct cause to it. So something that has, so it sort of goes from this, then that. So there's always just a direct relationship. So a good example, because there's lots of actual examples where that's the case, or that it appears to be the case, I would say. So let's say that you trip over and you twist your ankle and you break your ankle, and you kind of go, well, yeah, that was a direct cause between I tripped, I fell, and it was actually the fall that physically broke my ankle. And you can't argue with that. That is the major event. But when we dig a little deeper, we start to go, well, what's the difference between, let's say, a little old lady twisting her ankle and breaking it, and an elite athlete running down, let's say, a rugby field, and accidentally twisting their ankle and breaking it? And we start to realize that there's a little bit more going on that leads into that. So for the little old lady, it might be the fact that poor vision, low muscle strength. She's got a lot of bone mineral density issues, so she's more prone to breaking her ankle. So a smaller force would actually cause it to break rather than a larger force. So we start to sort of pile on a lot of these sort of things that go, these are all the things that led up to that ankle twisting and then breaking. And then when we look at the elite athlete, it's a case of, well, actually were they overtraining? Were they fatigued? And that sort of led to the misstep. Was there something happening on the field that took their attention away from where they were placing their feet? Was there actually someone that they tripped over? So did someone actually try and tackle them, clip them a little bit? And that's what caused them to then twist their ankle. So if we're thinking about understanding how an injury occurs and therefore how to prevent it, we start to see there's a little bit more going on. And so we know this in ACL research is probably the best one, is that we see, depending on the sport and depending upon the individual, there's lots of different factors that go into why someone injures their ACL. And therefore, if we want to prevent it, it has to be sport and individual treatments. It can't be that one thing. So if someone's going, I have, patellofemoral pain, I have plantar fasciitis, they have this specific diagnosis, there are specific things that we can say that we can follow through in that sort of cause and effect. So overtraining is a sort of a classic one. There are some things that we can identify and say, this is the thing that you need to change to either get better or to stop this happening in the future. But it's not a blanket thing that we can say for everyone. We can't just say, well, if you have this pain, then it's always about overtraining, or if you have this pain, it's always about a lack of strength. There's many different ways that injury occurs. So the example I often give as well, is a bit more outside of sport, is a match. If you take a box of matches and you light the match, you would expect the match to light up. And then you do that again in another scenario and it doesn't light up, and you go, well, hold on a second, I struck the match. That's that sort of event that you're seeing of twisting the ankle or landing funny and doing the ACL. But realistically, there's a lot of other things going on. There's oxygen in the air. There's the fact that your matches and the flint are dry. So those are the sorts of things that we just assume are the same, but they're not. And so if you're going to try and light a match in one scenario, you have to take into account things you can control, which is going to be, did you keep the matchbox dry? But there's also, and this is sort of where we get to with Cause Health's work, is that they kind of look at it and they say, there's going to be some things we can't control. There's going to be some things like, is there enough oxygen in the air? We can't often change that. And so when we sort of translate that to a sport environment, there are going to be things that we can't change. And by doing any sort of exercise or activity, there is a risk involved that we can't control. And I think there's that level of an uncertainty that adds, which we're not really comfortable with. And I definitely wasn't comfortable with as a clinician. All of a sudden, you want to know everything and you want to prevent everything, but really there's an inherent risk. And we have to sort of get a little bit better at tolerating that. And that's more of a cultural issue, because we're sort of sold when we're in a culture of we can control everything, when in reality, it's an illusion of control. That being said, it's not a case of, oh, well, you're going to get injured, throw caution to the wind. There's definitely lots of things that we can do that aren't always addressing cause and effect. So it's not always a case of, oh, you're at risk of this injury, and here's the things that we can't control. Therefore, what are we doing? It's a case of, well, actually, there's a lot of other things that might have nothing specifically to do with that injury. And this is where strength training sort of often comes in. So we say it's not a perfect injury prevention. It's not a perfect treatment. It's sort of this in between where we go, we can't control if someone's going to, come out of left field and tackle the rugby player. We can't control always when we're thinking about running, specifically, the tracks we're always going to be able to run on. The fatigue are, if we're having a bad night's sleep, but we still need to run. But what we can do is do things like get you stronger, train in a certain way that builds your capacity, so you have more tolerance for when these things that we can't control occur.
Okay, I forgot to mention at the start, you might notice that my microphone is a bit jittery, and I had a very bad microphone audio quality type of day. But nonetheless, you can still understand. I don't talk a lot in this interview, so bear with me for that one. But when Alex is talking about this particular topic and talking about like the nuances of someone, say, developing PHT, we're not necessarily looking for one cause or one presentation, and not everyone fits into one specific treatment path or diagnosis path or causation path. because everyone's completely different. And there's many reasons why PHT can occur. You could be overdoing your running, which I see a lot. People could just keep the same amount of running and just change the amount of sitting that they have. There might be an elite triathlete get PHT. There might be a master's runner with PHT. There might be someone who just likes to bike ride on weekends eventually develop PHT for whatever particular reason, because there's so many different populations, so many different reasons, so many different causes of PHT developing. There may be different deficits or different reasons. Therefore, the treatment needs to be completely different. So deficits at play, like discrepancies or factors that might eventually lead to PHT. You might be looking purely at a capacity point of view. Maybe you've increased the capacity of that tendon during a particular exercise, or maybe you've just changed your sitting posture and there's been no change to the capacity of the tendon. Maybe your running technique is different from another runner. Maybe your bike posture has put you in a position where that tendon is a bit more under compression and under high load during compression. And so with this really unique presentation, because everything's so multi-dimensional, you can see now that when someone puts onto, say, a Facebook group, I have PHT because of this, and what has helped you. And some people say, sitting posture really helped me. Changing my sitting surface really helped me. Changing my running technique really helped me. Whereas you might try those things and see no benefit, or see very little benefit, or it might make it worse. Who knows? It's just because there are so many different facets at play, which is where we'll delve further into this topic, further into this interview. So let's dive in a bit further with my conversation with Alex. If I am putting my clinician hat on now, I remember when I was working in clinics, when I'd have someone who is injured and comes in, it was almost like my job to find the cause. It was almost my job to try and fit this pattern and it all to make sense. And then once I did that, I was trying to fit all these pieces. And if I could find some sort of connection there, then I've done my job, because I've reassured the runner, this is because you've done this and therefore you feel this way. Therefore, this is how we should place or how we should position our treatment. Should we be okay with not understanding all the complexities and just moving forward through treatment? Is there any dangers in not finding a cause?
Yeah, so there's a few things. I think and especially because I try and teach this to clinicians, and it's hard because there's a lot of these sort of fears, and I think some of them are very well founded in the sense that, so if someone comes in, there are things that you can't miss as a clinician, that you should be very, very well aware of what we call red flags. So things that indicate a serious pathology might be present, things you can't miss. So that's number one. So when someone's coming in and we're not giving, I'm not always communicating a diagnosis, or not being very firm in exactly what we think it is, we should have gone through the process of saying, no, but it's definitely not these serious things, or it's not sounding like this. And if I have an inkling and I'm seeing a pattern of these factors, I will be referring for imaging, or I will be referring for a second opinion to go, this needs to be checked first. It's generally when we're looking at more of these sort of chronic or sort of slow onset sort of injuries. So things that are involved with a trauma. Non-traumatic injuries that we sort of look at and we can go, well, they're slow onset, they're not serious. These are the sorts of ones where there's a lot more complexity going. But I think there's also this sort of misnomer of, oh, you're not doing your job, or this clinician hasn't done their job. When really the flip side of understanding this is that, number one, we get so many different ways. Well, when we understand the human body, there's so many different ways to get an injury. There's also, by that same token, so many ways to get better. So there's not one pathway. So coming in, all of a sudden, it's very freeing for me, because I can go, well, this person has overtrained and they've developed this injury. That's what I'm sort of getting a picture of, or understanding a pattern. And so how do we get this person potentially, well, I think at least at the start, one of the things we should try is more recovery, But how do we keep that person fit? And so we could just reduce the volume. We could reduce the intensity. We could just cut out maybe one run and swap it for another activity. I can work with the athlete to then go, how can we keep your fitness up? How can we do all of this, but take load off this tissue? We can gait retrain. We can, get them in the gym and doing, changing their gym exercises so they don't, for example, patellofemoral pain. There's a bunch of exercises that don't put as much patellar compression on. And I can work with someone and go, well, it's not the fact that you are broken and we need to completely rest this, or not broken and you just need to keep going as usual. It's a case of, well, I can work with you to figure out what's a plan that's going to work for you specifically, based upon this idea of I've just got to maybe figure out which one I think is going to work, for you and for your condition. So volume, intensity, frequency, all of these sorts of parameters that I get to change your run or your gym session with, as well as specific therapies as well. So patellofemoral pain, it might be strengthening and orthotics. For plantar fasciitis, it might be stretching and taping. There's a lot of other things that we can do, or there's things that we know that will directly help it. I think the other sort of thing is to say, well, when we, especially with clinicians, they sort of go, well, so is all bets off? Can we do anything? And it's like, no. There's also patterns. And the idea is that we know that when someone comes in a certain age group, in a certain sort of sport, with a certain condition, that there's generally patterns of things that we see, and patterns as well for management. So if we're thinking about an adolescent with patellofemoral pain syndrome, taping and some reassurance might be enough, because we know that it's potentially to do with more growth. When we see someone who's an adult, they're running heaps and they're not strength training at all, it might be a combination of pulling back the running for a bit, strength training, a bit of gait retraining to help keep them running, and then build it back up. So immediately we can see these patterns that we can use, and then we can sort of use that understanding to customize. So I think this sort of approach is very freeing and very, very helpful, because it would absolutely suck if you were a runner. And I see this a lot. People come in, they go, you're going to tell me to stop running. And I go, I don't need to. I've got all of this lovely, wonderful stuff, these knobs and dials that I can adjust to help you. And here's the thing is that if I do all of that and then I go and you come back and go, it's a bit better, but it's not great, I've then got all this information about you and your response to that initial treatment. And then I can use that to help adjust my differential diagnosis. So what I think's going on, and I can use that to adjust how I do my treatment, rather than cookie cutter. Here's your orthotic, here's your taping, here's your stretching. It didn't work great, so now you have to stop running, or now you have to do this. And it's a case of, well, every study tells us everyone is different. Everyone responds differently. We just average it all out. And say, this is the result because we like one number. But realistically, when we look at any sort of study, we see everyone's response different. And we don't exactly have enough research to understand why their results are different. And that doesn't mean we can't look at our athlete, our patient as an individual, and they say, this is how I responded. And we go, okay, let's take that into account and figure out. So sometimes it will take me 3-4 sessions before I'm really confident exactly what's going on. But each step of the way, that I know there's something that I can do, and there's something that I should be trying, and there's something that I can be doing that can work for that person. And if it doesn't work, it allows me to understand them and make a treatment plan that does.
All right, let's unpack this one. So now previously we talked about like the assessment or the cause of PHT, there's so many individual factors or the unique presentation. And now we're sort of shifting towards treatment, and why one treatment doesn't work for everyone is because it's just so nuanced. And Alex does talk about how we need to tailor our treatment based on all of these individual factors that we've found, or that we've come to a conclusion based on the assessment, based on perhaps 2, 3, 4 treatment sessions, just to see how someone responds. And so just to, I guess, summarize, it'd be that there's little bits that we can do, which is like a stock standard treatment PHT. If someone is really flared up, someone is really sensitive, irritable, then we want to really limit their sitting in most cases. We really want to limit like high demands on that tendon in most cases. And then if we look at, like, say, the research, just starting some sort of loading, maybe starting some isometrics, that level 1 strength protocol will work for most people. That's like your stock standard. But then we're taking individual factors and trying to add in effectiveness based on them as a person, based on their unique presentation. And so if they're a triathlete, maybe there's something that we can do with their swimming so they can still stay active. Or maybe if they're just like a master's runner, maybe it's changing their terrain or their speed or their technique, changing their cadence just to try and increase the effectiveness of this particular, maybe it's just changing their sitting strategy. Sometimes I have people maintain their whole entire external workload with their training, but they just change their sitting, and that's enough to tick them over the edge towards recovery. And I really like when Alex talks about this adjusting the treatment dials, because then we're just using trial and error to see what the effectiveness is. So you can establish a management plan with a whole bunch of components. Maybe there's some strength, some sitting modifications, some exercise modifications, and then just general advice around sleeping, around how they negotiate work, looking after kids, those sort of things, just tailored to the individual. And then we just wait and see. This is the trial and error component, and seeing how the flare up or how symptoms respond, and then just adjusting the dials based on how you're responding, because we're not too sure. It's a guessing game. It's an educated guess, but it's still a guessing game to see how someone will respond. And we know the multi-directional, the multi-factorial pieces of pain, because sometimes emotions, sometimes stress, sometimes sleep might be involved as well. But it's just testing it out, seeing how it is, and then adjusting those dials based on how you're feeling, based on your response. And so that's a really nice way of summing up PHT and the uniqueness of it, and I guess understanding why one treatment might work really well for someone and just might have a very mild effect for another.
Well, it can be very freeing, like you were saying, and I know, position myself as a runner, if someone's injured, they're hoping to go to a clinician. They say, this is the cause of your injury. It's because you changed your footwear too abruptly. Now you have this pain, or you've overdone it. You've increased your running mileage too abruptly. This is why you're injured. This is your diagnosis. This is the treatment. Like, it'd be nice if everyone could fit into that, and everyone would be nice and reassured. They say, yes, I've got the plan. I know all the answers. This is what I need to do. But that's not what happens. That's not how life works. And what confuses runners is if they see multiple clinicians, there's different answers. People say, oh no, you have knee pain because your footwear. Oh no, you have knee pain because you're changing mileage. Oh no, you have foot pain, or you have knee pain because your quads are too tight, your ITB is too tight, you have weakness, tightness in all these different muscles, and you get a whole bunch of different opinions from different clinicians, which muddies the water. And then you're like, well, if no one can really give me a straight answer, how do we know what to do for treatment? But what you're saying is it's actually quite freeing, because yes, there are so many complexities to the cause, and so many different clinicians can make those connections, but the treatment can be quite freeing, because there is a lot we can do. No matter what the cause was, there's a lot that we can do, that you can just, like you say, adjust those knobs, turn the dials, and see how you fare with that management plan. And if you're faring quite well, then we know what we're doing is working, and we just keep moving forward. So I guess it kind of highlights that it is freeing, that we don't necessarily need to know the exact causes or the links between what's generated injury. We can follow patterns. We can follow patterns that we see time in, time out through being a clinician for years and years. But we can also kind of fit a pattern around symptoms, around how they respond to treatment. And if they respond well through a little bit of strengthening, then more strengthening and progressing that strengthening should be able to, follow that rehab path. Would you agree with that? Would you say that that's the reassuring side of things, or the freeing side of things when it comes to treatment?
Yeah, I would agree. I guess the thing is, though, when I think about it, there's still a lot of people that will come to see me and still have that experience of they come in and they've told me the whole story. And so really what I'm giving, and sort of what I'm talking about, is really sort of a look under the hood of how I think, how we know the research is telling us clinicians should operate. But there's lots of people that come in and I ask all the questions, I do all the things, and I'm putting this all together in my head. And, there's lots of patients that will go, look, what do I do? And, not everyone wants to know under the hood. Not everyone needs to know under the hood is really the thing that we actually know from research. There was a lot of research of understanding pain. And there was this whole thought of, if we understand pain, if everyone understands pain, then it's going to be really helpful. And the answer was not really. So there are still lots of people that come in that we ask all these questions, that we set everything up, and this is the map I'm putting in my head. But then, when it comes to the crunch, we say, okay, so they say, what am I going to do? I'm leaving here now. I need a plan. We write down, okay, what we're going to do to start with is we're going to change your shoes. Now, nice and simple. You need a new pair of shoes. Here's the shoes that we're going to get that I think are going to be better. Here's how you're going to wear them in. Here is your running plan. Now here's what the adjustments that you're going to make. And then here's your new gym program that we're going to start. So people sort of still do leave with a plan. And I think that's the misunderstanding when we start adopting this, is that we can still go in with a problem, still go in and get a diagnosis. We say, well, look, I think it's, first of all, I don't think it's bad. Second of all, so it's not a serious pathology. But second, I'm pretty sure it's, patellofemoral pain syndrome as a, really common example. And from what you've told me about all your training and all these things, these are the patterns that I know. And here's where I think we're going to start, so that people get the same experience, or can get the same experience. And it's more when we start to really talk about this and sort of introduce these ideas, and where I start to explain to patients is usually when they come in and they've seen multiple clinicians and they go, which one of these, what am I supposed to do? And I sort of do the, por qué no los dos? Why not? Why is it not all of them? Why is it not both? Is it my glutes? Is it my this? Is it my that? And it's like, well, it could be all of these are contributing. We've just got to figure out what we're doing, because doing one at a time is not enough. Or just addressing one at a time. We might need to have a more detailed plan for your specific injury. And we might, in some cases when things persist, we might need to look outside of that specific area as well. We might look at sleep. We might look at diet. We might look at, some people, we have to have the hard chat and say, well, look, you're trying to fit in this much running and this much gym with this work, that's taking up your life, with this much stress, with this much sort of family sort of stuff going on. There's a level of, is your body able to recover enough from everything that you're doing? And sometimes we have that discussion because we know you might be doing everything correctly. And this is, when we talk about, this understanding of complexity, the environment that we're in, all of these factors outside exactly what's happening. And it might just be the fact that they're just not, doing everything normally and just not able to recover because of stress, all these sorts of things affecting their life. And that's probably something that I see a lot a lot for people who come in confused because they go, I've done everything like I normally done. Now I've got an injury. And we sort of go, well, what else has changed in your life? And it's like, I've got a stressful job, now got a kid, now got a family, now got a dog, now got a mortgage. And all of these things are stressful, but the training remained constant. And it's like, well, your training needs to change because of all of these other things that are going on. Now, not to freak sort of anyone out, because that's out of the percentage of runners that I see, how many of those people do I have to have that hard chat with? Thankfully, not many, but it's in the back of my mind that, that's the sorts of things that I think about, that if someone isn't spending time recovering and they can't change it, that's how I'm setting my plans. That's how I'm thinking about doing what on what day. So that's in the back of my mind. That's a thought process that I'm having. And that's sort of the problem when we get cookie cutter plans and clinicians that aren't thinking about that. And we aren't educating us to say, these are the questions that you should be asking to determine if your clinician is doing it or not. That's what's sort of going in under the hood. And so it sort of can help people. I think if people understand and they want to know a bit more what's going on under the hood, that can be quite helpful at sort of getting over those common misconceptions and ideas or issues.
Okay, I thought I'd just chime in here just to make it a little bit clear, or at least give my thoughts on this particular topic, because there's been, I guess, people, especially when PHT has been carrying on for a long period of time, they see multiple different health professionals, see multiple different of the same health professional, and they just try different things to get multiple treatments, and they say, oh, has anyone looked at your running technique? Let's do this. Or, oh, has anyone assessed your running shoes? Let's do this. And you're not getting better because you're not addressing XYZ. And a lot of people with PHT, especially chronic PHT, they come to me like on social media and they say, I have tried everything and nothing helps. And they get the sense that they've tried everything because they've been to so many different health professionals or specialists or surgeons, doctors, a whole bunch of range of professionals who have all had their little take, had their little piece of advice, piece of wisdom of this is the treatment you should go with, and then nothing long-term comes of it. And so it creates that dread. It creates that sense of like, I've just continued trying everything and nothing helps. But I feel like with this particular conversation and this topic, you shouldn't really be fearful of someone who introduces like these different treatments and doesn't work, because we understand that we're just trying new things over and over again. And there is so many different approaches that you can take. And this is just another approach. If you do it correctly, just identifying, okay, we just haven't got to the crux of what will then turn into a long-term recovery plan. So it's just trying new things, and so many different options are out there for you. And if you just continue exploring the nuances within your life, continue exploring the individual factors within the specific injury, really try and find someone who really gets every aspect of your life, and trying to identify, okay, why isn't this getting better? Is it the stress? Is it the sleep? Is it your fears, doubts, and beliefs about this particular injury? And just really trying to hone in on a lot of those things and try a whole bunch of those things. And I think it's worth just knowing that you can keep trying until you get it right. I know we've had Ted Charnitsky on in the past, he had PHT for a decade and was just constantly trying different things until he found something that worked. And then he continued doing more of that thing that worked and had a resounding success. And so this is where this particular conversation can enlighten a lot of people and get rid of a lot of fears and those doubts.
Okay, well, let me pose this one to you. Mm-hmm. How important is a diagnosis? How important is having that label for the clinician and also for the runner coming in with pain, and knowing that there's multiple things that could lead to this pain presentation they currently have? How important is it that they have a label attached to it?
For a clinician, I don't think it's incredibly important. There's a lot of research and a lot of papers sort of showing that when we have a diagnosis, it doesn't actually tell us a lot about recovery. It doesn't tell us a lot about exactly how to treat it. A diagnosis is essentially a pattern of symptoms and things that we know consistently match with this type of injury. And, you know, we've even got a lot of sort of studies showing that imaging in certain circumstances is not incredibly reliable. So we see lots of tissue changes that can occur quite naturally, you know, sort of like a slight wearing down of a tire or a, bark on a tree. They're things that we expect to see of people of certain ages and certain histories in certain sports. So for a clinician, it's not always incredibly important for me to have a diagnosis if I'm doing my due diligence, I'm ruling things in and out, because there are some times where a diagnosis is incredibly important. For patients, I do think it's important to communicate a diagnosis, just simply because it's helpful. I mean, number one, we're taught, go in and get a diagnosis. It's illustrating that we've done a thought process. It's illustrating that we are thinking about it. And often we will reach a differential diagnosis. The difference is between me and potentially someone else is that I don't hang my hat on it, and I don't make all my decisions based on that diagnosis. So I'll still have one. And I still do communicate, and I go, but I'm not committed to it. I'm not saying that this is what it is, because if I get new information, I want to be able to go, well, actually, I don't think the diagnosis fits anymore now that I've got this new information. Because my appointments are 1 hour for an initial, so they're quite long for compared to many others. But even then, I've only got an hour with you. I'm not able to get all this information that I can be 100% certain. but I have enough information that I will tell people, well, it's definitely not something incredibly serious. That's not what I'm suspicious of. Or if I am, you're off for a scan or you're off for a second opinion. But this is sort of where I'm thinking it's coming from. This is sort of what I'm thinking it is. And here's all of these sort of things that we're going to do to sort of test my hypothesis. And at the same time, if it's helpful, then we've started your treatment journey. If it's not helpful, we go back, we have a chat about, what happened and why, and we figure out, is this a response that tells me, I might have been wrong, and I've got this more information to update my diagnosis? Or does it tell me that, okay, no, this does sound like the diagnosis. I've seen this before. It's just that this treatment or this management sort of strategy is not working for you, and we're gonna workshop that.
Yeah, I like how you say that all a diagnosis is just a pattern of symptoms, a collection of symptoms that sort of fit the mold. And I was talking to Ian Griffiths last week around plantar fasciitis and saying, like, I've seen so many before, but not all are the same. Like, you can get that pain under the heel, and you can say, okay, I'm quite confident this is plantar fasciitis. But then there's some other things, like there's 10 to 20% of symptoms that just don't make sense. It's like, oh, but I also get like burning or like radiating symptoms further up the shin or like further down to the toes, which isn't that classic. And you're like, okay, well, most of what you're describing seems to be plantar fasciitis, but there's a whole bunch of other stuff that doesn't really fit the pattern. So diagnoses wise, like we can say it's plantar fasciitis, but who knows how you respond to a classic plantar fasciitis treatment. So levels of severities and like durations, and like you say, dealing with the individual themselves, dealing with stresses, dealing with diet, dealing with sleep, all this sort of factors just get thrown in to create a totally different presentation. And what we know, I've done several episodes on pain science before, someone's experience, someone's interpretation, someone's alertness, hypervigilance towards a certain injury can just create a different pain experience, like to, more widespread or more severe or more irritable. So this becomes super, super tricky. And when we're talking about a treatment after that, we have to take in all of those factors so that the plan is just molding to the individual rather than that little sort of thing.
Okay, last little chime in here before we finish up part one. Talk about like the diagnosis and label. Some people with PHT, sometimes they can have sciatic nerve involvement. Sometimes they can have like a tear at the attachment. Sometimes people can have glute muscle involvement. Like there's just a mix of symptoms. Some people can have a purely 100% PHT. Some people can have PHT with like 10% nerve involvement. Some can have PHT with 50% nerve involvement. It's just really tricky. So when it comes to a diagnosis, while PHT as the label is the kind of what people hold on to, the treatment might be extremely different, or the symptoms themselves might be extremely different. And if you talk to 10 people with PHT, some people complain of like symptoms radiating down into the hamstring muscle belly, or some people have dull pain, some people have sharp pain. And where this diagnosis and label discussion is important is because previously when we discussed like a whole bunch of different treatments, a label and a diagnosis isn't that important as long as you are responding to treatment. And if you're not responding to treatment, then circumstances need to change, management plans need to change. And so a lot of times I may say, okay, you have PHT, but there's a few other symptoms, like 10%, 20% of symptoms that we just don't know why they're going on. However, let's treat it like PHT and let's see how things go. If things don't respond, or things respond quite well initially and then plateau out and we don't see that much improvements after that, then we might say, okay, let's continue that, but let's add in something else. Maybe we add in some treatment modalities to help with nerve issues. Maybe we do some nerve flossing type of exercises and see if that helps treatment. So we're using a management plan to evaluate a diagnosis in the same way, and we're not just fixated on the diagnosis and the label at the start. We're just, depending on management, depending on symptoms, continue like reiterating, continue modifying, continue taking things out, adding things in to provide the most effective thing for you. This sums up part 1. We're going to do a very, very similar thing, continue our conversation with Alex in part 2. So I'm looking forward to bringing you that next week.
Thanks once again for listening and taking control of your rehab. If you are a runner and love learning through the podcast format, then go ahead and check out the Run Smarter podcast, hosted by me. I'll include the link along with all the other links mentioned today in the show notes. So open up your device, click on the show description, and all the links will be there waiting for you. Congratulations on paving your way forward towards an empowering, pain-free future. And remember, knowledge is power.